Hello everyone. Welcome once again to my channel, Pathopedia with KT. And as I mentioned in the previous video, the purpose of this channel is to bring to your convenience simplified explanations of the various topics or disease conditions discussed in medical nursing. We have realized that in the past, before we will be able to gain a deeper understanding of these disease conditions, especially with the pathophysiology, we have to review lots and lots of books in order to locate key information that will help you have a very good grasp of these topics. But we all know that we are trying to make life much more easier for ourselves in all aspects, in terms of transportation, in terms of communication, and the rest. And I believe our studies shouldn't be an exception. Our studies should be as stress-free as possible. So as we move on, we would break down and simplify most of these contents so that you'll be able to really appreciate these conditions that you may find challenging by reading on your own. So in the first video, we talked about the pathophysiology of hypertension, the introductory part. So this happens to be the part 2 of the pathophysiology of hypertension. And we said that our key thing to note, or our key concept to note when it comes to hypertension, is this mathematical relation. That is, blood pressure is equal to cardiac output times peripheral resistance. We said this means that blood pressure is directly related to cardiac output and peripheral resistance, which in simple terms, we are trying to say that if the cardiac output increases, it means automatically the blood pressure will increase. The same thing applies to the peripheral resistance. If it increases, the blood pressure will also increase. And in the other way around, if the cardiac output decreases, the blood pressure will decrease. And if the peripheral resistance decreases, the blood pressure will decrease. So these two, cardiac output and peripheral resistance, have a direct influence on the blood pressure. At this point, if you have not had a look at the first video, I recommend you do so that you can really appreciate and follow the discussion we are having right now. In the first video, we delved into cardiac output and peripheral resistance, what it means, and the various stuff that are related to it. So if you've not watched it yet, take a second and have a look at it before you move on to this one. Good. So today I want us to look at a very important system that also has an influence on the cardiac output and the peripheral resistance, and for that matter, has an influence on the blood pressure. And this system is what we call the renin-angiotensin-aldosterone system. But before I move on any further, I wish to put this across. If you have any topic or condition in medical nursing that you would want us to review, kindly put it in the comment section and I'll be glad to work it out for you. So let's move on. So the renin-angiotensin-aldosterone system is a system that is always activated whenever the amount of blood flowing to the kidneys is reduced. That is in cases of reduced blood pressure and reduced blood volume. In the case of hypovolemic shock, hypotension, and the rest. Once the amount of blood entering the kidneys is less, the kidneys are able to sense it. And therefore, they assume that once they are receiving less blood, it means in the whole body, the blood pressure and the blood volume is low. So they activate this RAS system in order to increase the blood pressure and the blood volume. So you see that this system is very useful in situations of shock, in situations of low blood volume. But in hypertension, the blood pressure is already high. So should we allow this system to be activated to further increase the blood pressure? You know the answer is no. Yes, it can happen. A person might be having a high blood pressure in the body, But because perhaps there is a partial obstruction in the blood vessels of the kidneys, like the renal artery, assuming there is something like atherosclerosis in the renal artery, whereby blood flow to the kidneys is reduced, the kidneys will assume that because it is receiving less amount of blood, the whole body has a very low blood pressure and volume, and it will activate the system and worsen the high blood pressure. What goes into this system? Whenever there is reduced blood flow to the kidneys, that in situations of low blood pressure and low blood volume, the kidneys have some cells called the juxtaglomerular cells. They are able to detect this and they will release a substance called renin. Once renin is released, renin functions by converting angiotensinogen into angiotensin 1. Angiotensinogen is a plasma protein produced by the liver, but it is in inactive form. In medicine, whenever you see the word nogen, N-O-G-E-N, attached to anything, it means that thing is not active yet. Just like we have pepsinogen, meaning that inactive form of pepsin. So the same thing applies to this. So the liver releases angiotensinogen, which is inactive. But once the kidneys are able to release renin, renin is able to convert this angiotensinogen from its inactive form into angiotensin 1. Of course, we are expecting angiotensin 1 to be active. However, it is not so active. The most active form is the angiotensin 2. So after renin converts angiotensinogen to angiotensin 1, the lungs will release an enzyme which is called angiotensin converting enzyme, that is ACE, to convert this angiotensin 1 into angiotensin 2. This is the most active form that we are looking for. So once angiotensin 2 is formed, it has two impacts. The first one is that angiotensin 2 is able to cause vasoconstriction. It causes the blood vessels to constrict or to narrow. And we remember that once the skirt becomes too tight, I remember I used the analogy of a lady wearing skirt. Said when the skirt is too tight, that is in constriction, it inhibits the lady's movement, or it affects the lady's movement. So the resistance is more. So because angiotensin 2 causes vasoconstriction, it will make the blood vessel very tight and therefore increase the peripheral resistance. So blood flowing through the vessels will meet so much resistance. And we all know that peripheral resistance is directly related to blood pressure. So once peripheral resistance increases, the blood pressure will also increase. Another thing is that the angiotensin 2, once it is released, apart from the fact that it is causing vasoconstriction and increasing peripheral resistance, it also causes the release of a hormone called aldosterone from the adrenal gland. And once this aldosterone is released, it goes to the kidneys and stimulates the kidneys to reabsorb more water and sodium into the blood. And remember that the more we have water in the blood, we are increasing the blood volume, and for that matter, we are increasing the cardiac output. So the cardiac output increases, and we all know that just like peripheral resistance has an influence on the blood pressure, cardiac output also has same. So once the cardiac output increases, the blood pressure will also increase. So you see that whenever this system is activated, the end result is an increase in the blood pressure, which we are trying to prevent in cases of hypertension. So that ends the introductory part of the pathophysiology. So now let's move on to the pharmacology. That's the drugs used in managing hypertension. If you really understood what we have discussed so far, the pharmacology shouldn't be so much of a deal for you, because now we know that for the BP to increase, it is because of an increase in cardiac output or an increase in peripheral resistance. So if we are making a drug to reduce the BP, you agree with me that these drugs will work by either targeting one of these parameters that we have talked about. So we have drugs that will reduce the cardiac output, knowing that definitely the blood pressure will reduce as a result. Then we have drugs that will reduce the peripheral resistance. And for that reason, the blood pressure will as well reduce. Good. So we start with diuretics. When we say diuretics, they are just medications that works by preventing reabsorption of water and some electrolytes, therefore allowing them to pass out through urine. So you see that when you are on a diuretic, you pass out more urine, you pass out more water and electrolytes in your urine. And that is what you call diuretic. They work by inhibiting or preventing reabsorption of water, allowing the water and the electrolytes to pass out in urine. So we have various types. We have the loop diuretics, and that's the first one, furosemide. Furosemide is an example of a loop diuretic because it works at the ascending loop of the renal tubules or the nephron. So it works there by inhibiting the reabsorption of sodium, water, and the other electrolytes. Then we also have the bendrofluometazide and the others. They are called thiazide diuretics. They also work at the distal convoluted tubule within the renal artery. And just like the loop diuretics, they work by inhibiting reabsorption of sodium and water, therefore allowing the water to pass out in urine. These two, that is the loop diuretic and the thiazide diuretics, they also allow excess passage of potassium in the urine. So you lose potassium whenever you are on these drugs. Therefore, we call them potassium-losing diuretics. Apart from the fact that you are losing water and other electrolytes, you also lose more potassium. So furosemide and bendro, as well as the other thiazide diuretics and the other loop diuretics, they are called potassium-losing diuretics. Then we have spironolactone. Spironolactone, on the other hand, is a potassium-sparing diuretic, which means that, yes, it will allow you to pass out more urine, but it will not allow you to lose potassium. So when you are on this drug, your potassium levels will remain normal or even increase because potassium is being spared. An interesting thing about these medications, when it comes to furosemide, when you are on it for a long period of time, it is linked to ototoxicity, that is impairment in hearing. Then the thiazide diuretics will be linked to the development of gout and the others. So I think you can read further that. Another class of drug that is used to manage hypertension is the vasodilators. But before I even move on, I wish you could write in the comment section which parameter discussed earlier does the diuretic have influence on. So we have said that diuretics will make you lose more water from the body. In that case, which aspect are we talking about? Is it having an influence on the cardiac output or the peripheral resistance? And I believe your guess is as good as mine. You know that once you are losing water, you are reducing the cardiac output and therefore you are reducing the blood pressure. We have vasodilators, as we have said. For vasodilators, as the name implies, they work by dilating the blood vessel, opening up the blood vessel. And remember that when we open up the blood vessels, we have created so much space for blood to flow. So the peripheral resistance will reduce. And once we are able to reduce the peripheral resistance, we know that it has a direct influence on the blood pressure. Therefore, the BP will also reduce. Examples are hydralazine and sodium nitrochloride. Another class of drug that we use in management of hypertension is the adrenergic blockers. There are some receptors in the body which we call adrenergic receptors. You can find some in the heart, some in the blood vessels and others. Whenever they are activated, they have a particular effect on the body. So we have the alpha adrenergic receptors, the beta adrenergic receptors, and the rest. So alpha adrenergic receptor, that is alpha 1, whenever it is activated, it is found in the blood vessels. And whenever it is activated, it causes constriction of the vessels. Alpha receptors, whenever they are activated, they cause the blood vessels to constrict. And remember that that will increase peripheral resistance and therefore increase the blood pressure. So we have this drug, alpha adrenergic blockers or alpha adrenergic antagonists, which will block this alpha. And once we are able to block alpha, instead of it allowing it to cause vasoconstriction, once we are able to block it, there will be vasodilatation, and therefore the peripheral resistance will drop. And we all know that once it does that, the BP will also drop. So example of alpha adrenergic receptors blockers are prazosin. They end with sin. So we have prazosin, we have terazosin, and the rest. So any drug that you see that ends with sin falls under alpha adrenergic blockers. And these drugs, apart from their use in the management of hypertension, they can also be used in situations of enlarged prostate. They also relax the smooth muscles in the urinary system. Good. Then, once we have talked about alpha, we also have another adrenergic receptors called the beta adrenergic receptors. And with the beta adrenergic receptors, you can find some of them in the heart, some in the blood vessels as well. So when they are activated, what do? They increase the heart rate. Whenever beta adrenergic receptors are activated, they increase the heart rate. Then they also cause the blood vessels to constrict. So we are giving a drug to block beta. We have beta blockers or beta adrenergic blockers, or sometimes you see beta adrenergic antagonists. That means it is blocking the action of beta receptors. So once we are able to block beta receptors, instead of the blood vessel constricting, it will rather dilate and therefore reduce the peripheral resistance. And reducing the peripheral resistance means we are reducing the blood pressure. Good. The same way, if we block beta receptors, because they are known to increase heart rate, when we block them, they reduce the heart rate. And mind you, heart rate also has an influence on the cardiac output, because if the heart is pumping so fast, it means the amount of blood coming out will be more. And therefore, to increase the cardiac output and the BP will increase. So this drug will block the beta blockers. They will block the beta receptors. And for that reason, they will reduce the heart rate. And reducing the heart rate means they will reduce the cardiac output and the BP will also reduce. Examples of beta blockers are atenolol, propranolol, and the rest. They end with bolol. You can read further on them. Then we have the calcium channel blockers. Calcium channel blockers. Whenever calcium is activated or calcium channels are activated, more calcium enters into the cells and causes contraction of the smooth muscles and therefore constriction. So calcium channel blockers or calcium channels, whenever activated, once they cause contraction of the smooth muscles in the walls of the vessels, they result in vasoconstriction. So here, we want to prevent constriction. Therefore, we give a drug to block calcium channels. Therefore, it will cause vasodilatation and reduce the peripheral resistance. And now we know that the peripheral resistance has an influence on the BP. So once we are able to reduce the peripheral resistance, the BP will also drop. An interesting thing to note about calcium channel blockers is that they have a side effect of headache. That is because they cause vasodilatation. And that is it. Good. For the drugs acting on the renin-angiotensin-aldosterone system, I would want you to give it a try, put it in the comment section, pick them one after the other, and explain their class as well as the mechanism of action. So the first one is aliskerin, which is a renin antagonist. You see that in this one, we know that once the renin-angiotensin-aldosterone system is activated, it is going to increase the BP. So these drugs are just to pick the key components of the RAS system and block them. So this one, aliskiren, is a renin antagonist or a renin blocker. Then the lisinopril is an example of angiotensin converting enzyme inhibitor, what we call ACE inhibitor. We want to prevent the action of angiotensin aldosterone system, which I expect you to put it in the comment section. And for ACE inhibitors, they all end with pril. So you see captopril, enalapril, lisinopril, and the rest. Then we have the angiotensin 2 receptor blockers. They also end with sartan. So losartan, candesartan, irbesartan, the rest. Good. So I would want you to pick one of them or any of them, mention the class of drug and the mechanism of action. And in fact, if you really understood the discussion we had about the renin-angiotensin-aldosterone system, you just understand it from that point. And this is just a matter of identifying what each component does and how we want to block or prevent that, so that at the end of the day, the system will not work for the blood pressure to increase. So that is the end of this series on pathophysiology of hypertension. I believe with just few slides, 11 slides or so, and a whole lot of pictures, it's quite okay for you to really have a very good understanding of hypertension, even without referring from the book. Going through this will save you so much stress of reading a whole lot of pages or flipping a whole lot of pages. Thank you very much for your attention. Like I said, if you have any topic you would want me to review, kindly put it in the comment section and I'll do so. So our subsequent videos will be dependent on the kind of conditions you would want us to discuss. Thank you very much. Bye-bye. See you again.